Hey, Jenna, I think we're going to get started. It's 11 a.m. Perfect. Okay. So just a friendly reminder, you guys probably can see on the screen right. Please do type your name, position, and facility affiliation into the chat box. This will help us keep track of attendance for grant purposes. If you are not from Montana and you're joining us from a different state, please include the state that you are from. If you have multiple people joining, please do include everyone's information, and we do ask that you please turn on your webcam if you are comfortable with that. All right, so today's agenda from 11 to 11:05, we'll just have Dr. Vince Colucci welcome everyone here. 11:05 to 11:15 will be Dr. Neil Koo doing a case presentation. 11:15 to 11:30 will be Dr. Jenner Minto on identifying metrics for antimicrobial stewardship. And then from 11:30 to 12, we really wanted to have a discussion with y'all today about what you're doing with your metrics in your facilities and answer any questions that you have. So I'll turn it over to Vince to welcome everyone.
Thank you, Erica. Appreciate it. Welcome everybody to our second installment in our antimicrobial stewardship series. We're really excited to bring this to you all. Again, this is our monthly AMS type webinar series, and so this is the second one. So let's keep her going. Again, as Eric had mentioned, we divided this up into a couple of different parts. There's an academic and a didactic component to it. They're all relatively short and concise and precise. And then we're going to have Dr. Koo today will present a short case. Again, we're not trying to pontificate. Rather, we're just delivering this from a platform where we want everyone to engage, and it can be educational for all of us. So please give us your feedback. We appreciate that on how we can do better, what might help, and so on and so forth. We would enjoy reading that feedback and using it. Up first is Dr. Minto, and I don't want to delay that because I know you're all waiting to hear from her. So Jenner, I will turn it over to you.
Actually, I am going to
remark there. It's just, I can't, Dr. Koo, you look great today, and based on my background, that's a fantastic. I got to do something with my sloppy office as compared to your nice presentation and your background. So just thought I'd throw that out. Dr. Jenner.
I'm actually going to hand this over to Dr. Koo first. We discussed early this morning and decided that his presentation might give a little bit of context to mine. So he is going to take my place and lead off today.
Well, thank you. Thank you, Dr. Colucci and Dr. Minto. So I would like to just start off with a little quick vignette of just a case of trying to discuss about how applicable, what Jenner's going to talk about in regard into looking at metrics and specifically the drug, the DOT, which is, something that we're going to be, that many of you are going to be asked to report as part of to NHSN. So, but it's not just going to be for reporting, but also what you could do to kind of assess your, how your hospital is doing and identify any issues that you may be encountering. So just to start with this, anyway, so this is just a vignette, kind of an example. During an annual report presentation to an hospital executive committee, the chief quality officer that pointed out that there are incidents of hospital onset and hospital-acquired C. difficile infection at the hospital has reached a record high. They've noted that in the past 2 years that the standardized infection ratios, or the SIR, has remained above the established benchmark that was previously set. And we'll go into that a little bit later on about what that meant. As they are getting scheduled to have another joint commission visit in less than a year, the committee chair wanted the CQO to kind of put together a plan to address this issue in preparation for the visit. Oops. So this chief quality officer met with the director of infection prevention and her team and assigned the project to them. The team investigated all the known factors associated with healthcare-associated C. difficile infections in their facility. And these include appropriate testing of suspected patients, contact precaution practice adherence by healthcare professionals, handling of contaminated surfaces and items, and finally, the environmental disinfection. Additionally, the infectious disease pharmacy also reviewed the antibiotic use as a contributing factor to the increased incidence of C. difficile infections. And so what the pharmacist did is they secured a copy of the report for the annual antibiotic use, which showed the following. And what it showed in this case is that there had been an increased use of antibiotic overall in their facilities. Now, so as outlined in this graph. Then further breakdown of the antibiotic use kind of revealed some increased use in the prescription of ceftriaxone. So they've broken down all the different antibiotics, and in this case, vancomycin, meropenem, certain anti-pseudomonal antibiotics, quinolones, ceftriaxone, and azithromycin. And what they've seen is that the yellow line, which is the ceftriaxone usage, has steadily increased since 2015. So chart audit and utilization review of all the practitioners who are using this antibiotics have shown the following. And what it showed that is that there have been increased ceftriaxone use as empiric antibiotic therapy in several diagnoses. Apparently, there are clinicians that like to use this for skin and soft tissue infections as well as urinary tract infections. They also have noticed that many of these, a good number of these patients will remain on ceftriaxone despite being availability culture results. So therefore, they're not adjusting their antibiotics based on the cultures. And then finally, many of these antibiotics will remain on ceftriaxone until they're discharged. So all three of these items have now been are felt to be related to the increased use of ceftriaxone in this facility. So in response to these findings, that the chart reviews and the antibiotic utilization review, the following measures have been implemented. So first is that their antibiotic stewardship program have implemented a set of clinical pathways for specific diagnoses that's embedded in their EMR to help clinicians on treatment. So which antibiotics to use and how to in these specific diagnoses. The second thing is that they have implemented a hospital-wide handshake stewardship program. And I'll talk a little bit about what that really means later. But it was started to kind of help promote de-escalation of antibiotic therapy once culture results are available. And then finally, they have also implemented an IV to oral antibiotic conversion protocol that will assist with the de-escalation antibiotic therapy and when the cultures are resolved and that patients are responding to their therapy. So these are kind of what I wanted to lay out is some of the uses that we can of setting metrics and looking at the antibiotic use, the DOT, as a way to determine, correlate with a finding, usually an infection control issue, and how to determine how can you respond to address those concerns. Additionally, all of these metrics can be used to determine the response of any interventions that you implement. So with that, I'm going to hand it over to Jenner.
All right, I'm going to do my best to share my screen. You are not seeing my screen is my guess.
We can see the PowerPoint pulled up, but it's point. Looks good.
Yep.
Now we're good?
Yep.
Nope. You're seeing the presenter view?
Nope, presentation view. You're good.
We're good. Okay, excellent. So I am going to talk to you briefly today about some antimicrobial stewardship reporting metrics. And I do want to disclose that what I'm talking about is not the be all and end all of stewardship metrics. There are numerous metrics out there, but what I'm going to focus on today are those metrics that we are asking facilities to report for the purpose of our grant. So I'm going to focus largely on the days of therapy metric. And Dr. Koo, please jump in if you have anything to add at any point during this presentation. I don't mind being interrupted at all. So why are metrics important? And I really like this new data from the CDC, this little graphic that shows that more than half of the antibiotics prescribed for select events in hospitals are actually not consistent with recommended prescribing practices. So just looking at this, we can see that 79% of antibiotics are not consistent with community-acquired pneumonia guidelines, 77% not consistent with recommendations for urinary tract infections. And then we see that 47% of fluoroquinolones that are prescribed are not appropriately prescribed. And then 27%, which is a little bit better, but still a lot of additional vancomycin use that isn't necessary. So as Dr. Koo alluded to, tracking and measurement of antibiotic use is really critical to identifying areas for improvement. So by knowing how we're using our antibiotics, that allows us to then evaluate our processes, so our policies and procedures. It helps us to know where we can improve. So lets us know where we fall on that continuum in the little diagram that I showed you before. So looking at our policies and procedures, are they being followed? Are there areas for improvement? Might we need to develop new policies and procedures as a result of the antibiotic use data that we're seeing? And then once we've looked at these policies and procedures and processes, as well as the antibiotic use, then we can start to look at outcomes. So with the changes that we have made using that data, are we improving patient outcomes? Are we improving antibiotic use overall? Are we seeing trends that show that we're improving resistance in our hospitals? There are numerous different outcomes that we can measure. This is just a brief list of examples. We can also see, are certain antibiotics being overused? If you notice that you're seeing fluoroquinolones being used almost exclusively, probably a good idea to look at fluoroquinolone use. Are certain disease states being treated inappropriately? So if we're looking at urinary tract infections and we notice that every patient that shows up in the emergency room and gets a urinalysis is being prescribed antibiotics, even though they don't have symptoms, probably we're not treating that condition appropriately. And then we can also look at things like our broad spectrum antibiotics being de-escalated appropriately. So like Dr. Koo said, once we have culture results back, are we de-escalating to more appropriate antibiotics? So this next slide has essentially the same information, just in a different format. So antibiotic use measures, what I'll focus on today is the days of therapy. And the reason for this is because this is the metric that we will be tracking through the state. Our process measures, so our development and adherence to facility-specific treatment guidelines or published guidelines even. Are we tracking recommendations or interventions? Do we have a process or a policy that says we need to do that? And then looking again at our different outcome measures. One that I have in here that I didn't include in the previous slide that is really beneficial is financial impact. So how are our antibiotic use data showing us that we are appropriately or inappropriately using antibiotics? Probably not. But what it can tell us is that if we start appropriately using antibiotics, our antibiotic costs may go down significantly. All right, so jumping into the days of therapy, also known as your antimicrobial days. What this metric is the aggregate sum of days for which any amount of a specific antimicrobial agent, so by specific, I mean one antimicrobial agent, was administered to an individual patient or patients as documented in the AU option. So this is a definition by the CDC, and the AU option is the antibiotic use option through NHSN. So an example for you, 1 day of therapy per antibiotic per day. So if you have a patient that is on azithromycin and ceftriaxone for community-acquired pneumonia, Patient is on this for 1 day. This is a total of 2 days of therapy, even though the patient only actually receives antibiotics for 1 day. So it's 1 day per antibiotic. Now, if you have a patient that's on amoxicillin every 6 hours for 3 days, they're receiving multiple doses of amoxicillin within that day, but it still only counts as 1 per day. So for 3 days, that would be a total of 3 days of therapy. And if there are questions about this, please chat in questions or interrupt. I don't mind being interrupted at all. When we're looking at our days of therapy or our antimicrobial days are stratified by route of administration. So we will look at how our IV versus intramuscular versus digestive and respiratory medications are administered. A question that Erica and I get pretty frequently is, do we include topical antibiotics, or how should we categorize our topical antibiotics? We don't see that on the drop-down menu on the tracking tool. And the reason for that is that topical antibiotics are excluded from the analysis with NHSN, so they're also excluded on our tracking tool. We also want to look at our antimicrobial days based on where they occur. So are we using antimicrobials differently in the ICU or med-surg or the emergency department? I noticed with a lot of the smaller hospitals that I work with, we'll see some differences between the emergency department and the medical or surgical ward. And this could be because we have different providers in those areas. Could be numerous other reasons for those differences as well. So that's why on your tracking tool, if you're using that, you'll see the location, and we want to break it down by that. We don't want to include overall antibiotics when you may be prescribing an antibiotic in the emergency department and then discharging, because we don't know how that follow-up will be. So to calculate our days of therapy, or our days of therapy per 1,000 patient days. So what days of therapy per 1,000 patient days is the number of our days of therapy normalized to a number that will allow us to compare ourselves to other healthcare facilities, also allows us to compare ourselves or a single institution across time. So if we have a month where census is very low and we want to compare to a month where census is very high, this normalizes that data. To calculate this, we divide our days of therapy by 1,000 patient days, or our antimicrobial days by volume, and then multiply. So the big question, how do we track and report days of therapy? There are a couple different options. The first being to report electronically to NHSN using the antimicrobial use or AU option. And I've included a link here. We will have these slides available to you on the Mountain Pacific Quality Health website following this webinar. So you will be able to click on the link and you don't have to write this all down right now. So this is a very good option. Another option is to report to DPHHS directly using the antibiotic tool that was developed by the Montana Hospital Association Rural Hospital Flexibility Program and is shared again on the Mountain Pacific Quality Health website. And I've included the link to that as well. If you are interested in reporting directly to NHSN, this does require an information system that's capable of submitting electronic medication records and or barcoding medication administration records. There are numerous health information technology companies. I've copied and pasted an image here that comes from the SIDP website that is linked on the CDC website. And these are the different AU vendors that are available to help with reporting to NHSN. There are currently 13 vendors listed on this particular vendor list. Depending on your software system, you may like one over another. There are a number of hospitals in Montana that are very successfully working with Azalva, which is Medici, to upload and help report to NHSN. This is really handy because what happens at the end of the year, hospitals give Erica permission to access their data, and then you don't have to worry about reporting or sending to us. Last checked, and I don't quote me on this because I haven't had the chance to confirm with the Medici folks recently. Last time I heard the cost was about $100 per month, which is actually pretty reasonable, particularly if you have a large enough census that you're paying somebody to manually input this data every month. Our other alternative is to report to DPHHS using this antibiotic tracking tool. And this is just a really quick snippet of what the information we would like you to enter. If we have time at the end after we take questions, I'll go ahead and share my screen and show you how to navigate through the antibiotic tracking tool. But we've done webinars on that in the past. So if we run out of time today, we can always make sure that we re-upload those webinars and you can see how to navigate the tool. So another big question that Erica and I receive on a regular basis. Well, we're sending you the data. What do you do with this data? So we have accumulating a large amount of data at this point. And what I have done as an example here is put together a comparison of our days of therapy per 1,000 patient days data for both our critical access and our PPS hospitals. So if you are here and you're from a critical access hospital, you would like to know where you lie on this continuum. Am I green? Am I blue? Am I brown? Shoot me an email. I'm happy to let you know. One thing I will point out about this graphic is that you'll notice some facilities like facility F, for example, looks like it has a very, very low rate of antibiotic use. And it does. But the reason for that is because there's an attached long-term care facility in that hospital. So when we're counting patient days, we're including the permanent residents as a component of that. So it doesn't necessarily mean that they're doing a better job of using antibiotics than some of these other hospitals. What it means is that they have a very different demographic. So ideally, if you're trying to compare yourselves to others, it's a good idea to find another hospital of similar size and demographic, talk with them and say, hey, can we compare our days of therapy data? Let's see if we're doing what we need to be doing. Are there areas to improve? So looking at this chart, if you look at the blue line up top, and then you look at the brown line up top, these two facilities are very similar in size and demographics. They're also two facilities that very regularly take swing admissions that require long-term antibiotic therapy. So just because they tend to be running at the higher end of this graph doesn't necessarily mean that they are not using their antibiotics appropriately. So while it can be interesting to compare yourselves to others, it's also a really good idea to get this kind of data over a series of months or years and compare yourself to where you've been in the past. So is your antibiotic use consistently increasing? Is it decreasing? Is it fairly consistent? So this is the graph of our critical access hospitals. The next slide is a graph of our larger PPS hospitals. And we don't have a whole lot of data from most of our PPS hospitals. So if you are on here and from one of our larger hospitals in the state, please send us data. We would love to include more. You'll also notice a couple of these bars had some missing months of data, so it's not entirely complete. Additionally, we can look at our days of therapy data to trend how our antibiotic prescribing is looking over time. So what I have here are some data sets from two separate critical access hospitals. You'll notice on the left-hand side of your screen, year 1 was purple, year 2 is green. So in year 1, we see pretty consistent antibiotic use. And then over year 2, we see a little bit of an increase in antibiotic use. What we also see when we look by year is that our antibiotic use overall has increased year 2 over year 1. So what are the reasons for this? There could be a lot of different reasons. What we came to the conclusion of was that in this particular facility, there had been a lot of repeated turnover from medical staff. So we didn't have any consistency with medical providers. And every time there was a new provider, we'd be starting at square one, trying to get the provider on board with the improvements that we had been trying to make. But it's a little bit difficult when you have new providers fairly regularly. So what we learned from this is that really this is not necessarily a process where you're always going to see improvement. It's kind of a step back, reevaluate, see how we're doing, re-educate, and make sure that we're doing the best that we can. And this second set of data is another facility, but this facility has had very consistent providers over the course of numerous years. So not much turnover in medical staff at all. And what we saw here, year one was the very first year they implemented an antimicrobial stewardship program. Year two, you'll notice that there was a decrease from year one. So I think that's really beneficial to show to your medical staff, to show to your C-suite. Look, if we actually implement these processes and procedures and actively engage ourselves in our antimicrobial stewardship program, we can see some pretty significant improvements in prescribing. And then finally, this is one of my favorite charts because this particular hospital has done an amazing job improving their fluoroquinolone use over the course of a couple years. When we initially started the antimicrobial stewardship program, pretty much every patient that was admitted to the hospital with a urinary tract infection was being prescribed a fluoroquinolone. And so we started looking at that regularly and doing some education about what are the risks versus benefits with fluoroquinolones? What are the alternatives that can be safely used? So what you see here is in that first year, there was a pretty consistent decline in fluoroquinolone use. And then even looking at the second year, there's still a little bit of decline in fluoroquinolone use, but what you're noticing is that even our highest point during that second year is substantially lower than it was when we started our stewardship program. So it's really nice to be able to look at these graphs and say, hey, what we're doing is working. It's also really nice to be able to look at these graphs and say, hey, wow, what we're doing is not working. And then step back and try and figure out what we can do in order to start seeing improvements like we see in these graphs. All right, that was a very abbreviated version of days of therapy, metrics, and what we are asking you to report to us. And now I just want to open up to questions either for myself or Dr. Koo or Vince.
Jenner and Dr. Koo, Dr. Minto, Dr. Koo, thank you very much for those presentations. That was great. So folks out there, if you got questions, I know you're all smart and smarter than me for sure. So what kind of questions do you have? Jenner, I'll start this off a little bit. So do the data that you generate, does that go back to the hospitals at a periodic time, or do they have to request it, or how does that work?
That's an excellent question. So we are right now working on putting together kind of a mini report with data for each of the hospitals that has consistently reported 12 months of data. It's difficult to report and send anything back to facilities that only sporadically report. So if I have a January, a March, and a December, we probably aren't going to be able to put together anything beneficial with that. But facilities that have reported over the course of 12 months fairly consistently, we will be getting reports back to the hospital. And the other thing I will say is that we are happy to talk to you at any point in time about what your data looks like. Even if you don't have a full year of data, shoot me an email and say, hey, I'd like you to take a look at my tracking spreadsheet, or I'd like you to take a look at our data in NHSN. Just get us started and figure out, where can we start? Are we overusing fluoroquinolones? That's something that if you don't work in pharmacy or not a provider, you may not be as familiar with. So I'm more than happy to talk with you. We can arrange a Zoom meeting, figure out some basic goals to get you started and seeing some improvement. Thank you for the question, Vince. That was a good one.
So this is Hugh from Kalispell. I think I got more of a kind of a clinical or clinician discussion regarding what I would say Rocephin. We've made initiatives here to move away from carbapenems. Ceftriaxone is a once daily IV antibiotic. It's relatively broad spectrum, very effective in cellulitis, UTIs. So empirically, it covers a lot of bases, even upper respiratory tract infections. So I'm moving from one drug to the other. Other drugs out there, I don't kind of like focusing on C. diff and trends, but like azithromycin has gotten a bad rap for QT prolongation. Our patients are elderly on antidepressants, on antiemetics. We're getting stacking drugs. We can't use azithro. Fluoroquinolones also have gotten a bad market share. So it's more about risk reduction and where are we pushing the risk to? Just like one of those internal discussions we have, like how do we make the selection? IV to PO. I mean, like that's we've been doing that here for a while. I don't think that decreases C. diff, but it's just like how do we optimize therapy when we get more and more risks out there with these patients? And ceftriaxone seems to be such an, unfortunately, easy, cheap drug. And I don't like using it that way, but that's just a real concern from the clinician standpoint and a patient safety standpoint across the board.
Yeah, if I may, I'll try to, I'll get a shot at this one.
Good.
Let me kind of first start off with, we were, Jenner and I kind of started talking about days of therapy as a metric. Let me say that honestly, it's not a great way to deter, well, let me say, it doesn't identify your problem. It's a tool used to help identify, to kind of correlate what you're seeing and what's going on. So I don't want you to come out of this, all of you coming out of this discussion thinking that, oh, we're doing this because it will give me an answer of what's wrong with our, what we're doing wrong in our facility. Now, granted, I know that every facility is being asked to do this, and so no one really thinks about what that, how to correlate that with any of the outcomes that are quality measures that you're trying to accomplish. It is a so with that being said, I mean, I'm not saying that you're going to that looking at your a DOT over time is something that's going to also say that you're doing something wrong. It's again, there are a lot of different factors that go into DOTs. You could, like right now, our use of antibiotics has shot up because of COVID-19, because and that's also not because many of these patients have co-infections like COVID-19 and pneumonia. It's because that it's hard right now. There is this. It's so hard for the clinicians to differentiate COVID-19 from true actual pneumonia. So we're seeing a huge surge in antibiotic use now. But is that telling me that is a problem? Well, that depends. It only is an issue if you're seeing complications related to antibiotic use, right? So C. difficile infections, adverse event. So if we're doing a lot more quinolones and we're seeing, then you're seeing more complications with like QT prolongations, or well, usually you don't see tendon ruptures as a result, but it is a complication. So what I'm getting at is that it's only a piece of the picture, but this is how NHS and the CDC use to try to standardize and compare what different facilities are doing. Now, each facilities will end up having to put together their own little metrics, and not just going to be the days of therapy, but ways that you're going to look at how this is going to work. And so that's where it gets a little tricky. And part of the reason we want to have the discussion is just to kind of to share ideas of what different facilities are doing to identify different issues that pops up, because not everyone have the same problems and not everyone will be able to address the issues the same way. So now to go back to this is that, yes, it's to your question is that, well, we're looking at this ceftriaxone's easy and such. Yes, we do use ceftriaxone quite a bit. I think that's probably, and I don't think that the use of ceftriaxone as empiric therapy is going to go away. What will help more is all the other things that you brought up, trying to de-escalate based on culture results, the IV to oral, and I mentioned about Handshake stewardship. This is something we are doing in our facility where our ID physician, there's an ID physician and ID pharmacist will actually be available and meet with our hospitalists, and actually will go through some of the things that get flagged up that the pharmacists have found, like culture results, antibiotic use and such, and actually try to nudge those clinicians into changing their antibiotic therapy or offer recommendations, which is usually what many of the clinicians would appreciate. Now, this is actually, obviously you will have to, in order for you to have something like this at your facility, you'll need to have an ID physician or someone who's comfortable dealing with antibiotics and such. So not every place will be able to do this, but this is an option if you happen to have that, or happen to have someone who's very comfortable with dealing with IV antibiotic or antibiotic therapy. So in the end, it's you find things, you use metrics to identify issues. And then you will have to tailor what you do, which metrics you're going to use and what interventions you're going to apply. that will fit your facility. So this is just one way, because this is what we're asked, everyone in NHSN and the state is asking for. But there are other metrics that you can look at. And so anyway, I know this is a long answer. There's no great answer, well, this is how you have to do it. And if your facilities choose to use Ceftriaxone as an empiric therapy, that's great. But if you're going to but you probably should have other ways, what you pointed out. Ways to de-escalate antibodies to everybody, to get them off of Ceftriaxone, because yes, it is also C. diffogenic, as we have shown in a lot of the places. So hope that helped answer your question.
No, that's beneficial. It's kind of reaffirming. I mean, we had some positive move, like moving away from carbapenems, I think is a positive sign for our organization. Our pharmacists are active in doing 1 day, 3 day, 7 day review and de-escalating IV to PO. So that's not really de-escalation, but actually stopping antibiotics. I wouldn't say what resonated with me is our patients with COVID have been much more difficult to manage in terms of antibiotic use. They're on steroids. They definitely have pro-inflammatory markers going up. They sometimes, I would say, they seem like they can turn at any moment from being stable to be very unstable. We can't identify the cause. So we have, we give them steroids, white counts up, CRP's up. Do they have another infection on top of this? We don't know. We just throw everything, and it's just, they're on antibiotics for 10 to 14 days because they're continued to have all these markers in this unstable situation. And it's hard to track at the moment and differentiate out. It'd be nice if I could cohort all our COVID patients into a different group. The way we have them spread out through our hospitals is making it difficult.
Now, you brought up a good point, and it is, I think that many of, all of our listeners here are going to, hopefully, after this webinar, is going to try to think of what can I do as a metric and what interventions I can apply. And all the things I'm telling you right now is just things that, that's been talked about in literature and things that I've tried. But on the other hand, it's, there's nothing wrong with trying to tackling small projects too. So you don't have to, I don't think that there is an effective way to curb antibiotic use in COVID-19 patients, but there are other things that you could do, that you could probably, that would make a significant impact. So don't feel like this is the only thing you can do. There are many projects, and that's one of the nice thing about antibiotic stewardship is there is not one way of doing things. There's you have a template that you should follow, and then you kind of find ways to kind of, tailor it to your own organization and facilities.
Thank you.
I did post a question in the chat if anyone's comfortable sharing, but we were interested, how many individuals on this call are directly involved with collecting your days of therapy at your facility, and how have you used this data? If anyone's willing to share that. And I'd love to hear from, critical access hospitals as well as PPS, because I do think how you're using that data might be a little different. I will call on people, I know that was. Tyler Hope, I'm gonna call on you first. Are you by chance have a microphone or can share? I know you guys are doing some great work always. Sounds like Peggy says, and she's with Madison Valley, which is a CAW. I share the use with the providers at the quarterly med staff meetings. Peggy, do you feel like quarterly data is helpful for your providers? And do you break it down by provider prescribing practices, or do you just do overall? Okay, so Peggy says they do overall and provider specific. Do you feel like your providers are pretty receptive if, one provider maybe has a little bit more prescribing than others or something like that? Are you noticing changes? They say it's helpful, but I did not see much change. Okay. Cindy, it looks like you might agree with something along those lines.
No, I was just chuckling at the remark about they haven't changed yet. It does take a little bit of time for that. So we are a critical access hospital. This is Roundup Memorial, and we have been struggling in starting this program. So I'm just very pleased to be here. I think you have some great ideas. I do have 2 pharmacists, one that oversees our intermediate swing unit, and then one that sees our acute and ER patients. So we have a meeting about this to kind of get started and develop our tools for tracking.
Awesome. Thank you for sharing, Cindy. I'm so excited to see what you guys do out there, because I know you kind of had a new team come in, and I'm really excited to see what you guys do. You seem very enthusiastic about infection control and AMS.
Well, thank you. We have a great infection control nurse who is very active, and that's very helpful for us.
Perfect. Dr. Koo, did you want to comment or say your comment out loud in the chat?
Sure. So and again, we're kind of talking about DOT and how to calculate and put this together. The other thing is that if you try to present this data, the DOT data, to a C-suite or non-clinical folks, or even clinical folks for that matter, or hospitalists, they won't know what you're talking about. And to them, it's hard for them to, you're not, because in their mind, especially for clinicians, antibiotics is an important part of their practice. So I don't recommend just taking that data and say, okay, we have a problem because this is our DOT graph is showing this, because it will make no sense to them whatsoever. You'll have to digest that and correlate what that really means. So just like my vignette, you have to identify the problem, which is the example was a C. difficile infection, and then you have to correlate that with the increased antibiotic use. And that will then translate to something that they can understand. So keep in mind, so in other words, you have all these other metrics going. So DOT is by itself really doesn't mean a whole lot without anything correlating with it. So I want to emphasize that, because as you're kind of putting together what you're going to do at each of your facilities, you can't start with DOT. You actually have to identify an issue first and then try to correlate that with your DOT. If you want to correlate antibiotic use as one of your issues, one of the quality as part of your quality measures that you're measuring. So.
This is Hugh from Kalispell. I got one more question. So we've used these metrics in order to do like a deeper dive. That's how I identified certain, I'd say, utilization, kind of targeted certain classes. I don't know if we really moved the days of therapy by switching from one drug to the other. Does it move that mark at all? What I'm trying to think about is the future. So, we're trying to incorporate more outpatient. I guess what metrics do you think will be measured in the future, kind of like days of therapy? I'm trying to figure out how to do this. We're looking at prescribers, some are urgent care. So they're definitely the high utilizers. It doesn't mean it's bad. I mean, so it's not really fair to compare someone that works at urgent care versus someone that's not working in urgent care. So I'm just trying to figure out what measures will we need in the future just to be a little bit ahead.
So see if Jenna and Vince want to chime in, or it's a B again.
I'll let you answer first and then I'll chime in after.
Well, so outpatient antibiotic stewardship is actually another big, a totally different ball of wax. And I'm just going to say it right now, because you're losing a lot of the things that you can't do. DOT doesn't really apply to outpatient, obviously, because you're not tracking what the patients are taking, because no one's monitoring that. And so the best you could do is the prescribing habits and how many prescriptions are being written. So that, I mean, because you don't know. So you see what I'm kind of saying is that in the hospital setting, you can track because the nurses are documenting each day if someone's getting their medication. So I think that so you have to do a very different approach, and you have to look at it more based on diagnoses, and antibiotics prescribed. So for example, you know, number of urine cultures that's been that's performed, and then correlate that with antibiotic use, because you're seeing, okay, is there a correlation with increased antibiotic use within, and you know, then you're going down that path of asymptomatic bacteria and things like that. So that's something you can kind of look at, or the number of otitis media and such, yeah. And it's not going to also, it's also going to look at which antibiotics they're going to be using. You know, do we need augmentin every time for a kiddo with a ear infection? I mean, so things like that. Those are things that, or UTI. So it's those are the things that you're probably going to be using more of in the outpatient setting than in the inpatient setting, where we're looking more for trying to get them off of the big broad spectrum antibiotics and try to minimize the risk of you know, developing complications with antibiotic therapy, because you know, that's where a good chunk of, you know, where obviously IV antibiotics are being used, and clinicians, again, we kind of talked about this, they feel very comfortable. They enjoy having an intravenous antibiotics because of that sense of security. And that's the hardest part to nudge them away from, because in their mind, the stronger the antibiotics, the better it is, and I'm safe, and nothing's bad's going to happen. So that's one of our jobs as antibiotic stewards is to nudge them away from that, and that's hard because it's ingrained in us, all the clinicians.
Yeah, that's a great question, Hugh. And I'll throw this perspective out based on my experience. Years ago, we did kind of an outpatient look at antibiotics, and I would suggest that you need to look at different areas, and kind of what Neil was saying, what Dr. Koo was saying, is that look at the different patient populations in the different cohorts. So for instance, if it's an ER, if it's an urgent care, and then separate what kind of antimicrobial use you're looking at, and for what diagnoses. So if it's pharyngitis or upper respiratory tract infections, and kind of hone in on that. And then is everybody making the right choice? And so if people are coming in looking for an antibiotic, where does the education necessarily need to be? Well, there's a component of it that needs to be with the patients coming in. And so that whole aspect, who's doing the screening? Is it the nurse, the pharmacist, and so on and so forth? Those folks need some education in terms of what can be done. Is it a viral upper respiratory tract infection that's not going to be requiring antibiotics, or is it something different? So you don't need antibiotics. We're not going to throw a bunch of antibiotics at your viral cold, even though the patient may think that they need it. So I think it's kind of a triple-headed beast sometimes, the prescribers and the middle triaging individuals and the patients. And then, looking at that, you can kind of narrow that down. And so picking out who the offenders are. And there's a lot of different articles that have been published, for instance, giving them a prescription, but not necessarily filling it, or giving out a little viral cold pack that has acetaminophen and Kleenex and some nasal decongestant type of a deal, but not going home with an antibiotic all the time. So I think you have to kind of get down and dirty and get in the weeds and look at what area you're treating at, and then try to focus on that area specifically. That helps.
It does, but maybe I'll look at ivermectin next. I'm not joking.
Yeah.
It's funny that you mentioned that. One of the aspects of outpatient antibiotic stewardship that is different from inpatient is that you're not just dealing with the clinicians, you also have to deal with patients and family members. So the efforts are not just going to be directed telling what the clinicians think, because many of the clinicians are dealing with patients coming in requesting specifically for something. So, which is a little, which is a little bit different in the inpatient setting. Well, until now, but yes, like the ivermectin. But for example, if someone comes into an outpatient setting, a lot of patients are going to want antibiotics for their sinusitis or their presumed UTI or whatever. That is the expectation set. So part of that is actually trying to set up a way to educate patients as well as providers. So that's why I want to say it's a little bit different in outpatient, because in the inpatient setting, you're controlled, and really it's mostly the clinicians until now with the ivermectin. And we actually, just to let you know, we at Billings Clinic are putting together a patient handout with a set of expectations for the patients and their family members of COVID-19 to say, this is how we're going to treat COVID-19 here. And so it's kind of similar. It's like, these are setting those expectations so that there are not going to be these requests for inappropriate therapy. And you probably will could do the same on an outpatient setting, that you may have, majority of the acute rhinosinusitis do not need antibiotic therapy, but you can have a handout for the clinicians to provide to their patients that this is how we're going to manage it, and this is what you can do to alleviate your symptoms. So that the clinicians don't feel pressured to just write a script for Augmentin or whatever.
And I'll just jump in. I wanted to make a quick comment about your comment that if you switch from one antibiotic to another, you're getting rid of the carbapenems, but you're transitioning to ceftriaxone. So your days of therapy aren't decreasing. And I think, like Dr. Koo said, days of therapy are very helpful, but they are not the be all and end all. And I think that you need to start looking at other metrics or other potential issues of using carbapenems and use those to be encouraging the providers. So by transitioning, your days of therapy are staying the same, but you're preserving those carbapenems for the patients that need them for more severe infections. You are not necessarily seeing resistance to carbapenems that you might see if you were overusing the carbapenems. So there are definite benefits. And if you're not seeing a lot of resistance right now, it's not something that you can necessarily say, hey, we're seeing a lot less resistance, but you are preventing that resistance from happening. So just because you're not seeing a change in that number, that days of therapy number, doesn't mean that the interventions that you're making aren't beneficial in the long run.
So this is Cindy again from Roundup. I am one of those very unique critical access hospitals. I do have the what most people call the long-term care unit. So I have 17 residents there, and we already had started monitoring antibiotic use for urinary tract infections on that portion of the hospital. So my question really is probably for Dr. Koo and trying to develop my story. I do have good reception from our providers, but I don't really have a story of C. diff or of any other abnormal antibiotic events. So can you think of anything else I might use to capture the audience as we get started?
That's a good question. And that's not just trying to convince, but in general, is figure out the why. What's going to motivate them to do things, and yes, it is easy to see if we have an outbreak of C. diff or an outbreak of or some other complications that you can correlate that with antibiotic use, and then you can show the metrics. Alternatively, I would say is that the fact that you don't have C. diff is actually a good reason. And you say, look, we're doing great and we want to keep it that way. And that is probably better in a lot of ways, so that you now have everyone invested in that, hey, we as a group want to keep it that way. So this is what we need to do. So so it's the same thing if I'm asking, you don't have an outbreak or you don't have an outbreak of COVID-19, we want to keep it that way. So.
And Cindy, I think another thing that you can look at that I have looked at quite significantly with the nursing homes here in Missoula is what resistance patterns you're starting to see with the organisms in urinary tract infections. So what we did was an analysis over, at this point, we're almost at year 4, over what the resistance patterns were looking like. And what we found is that the resistance trends within the specific facilities were quite different than our local resistance patterns. So that was something that we found very beneficial, was looking at what antibiotics might work for the general population. And they might be prescribed in a hospital based on a hospital antibiogram, but aren't necessarily as appropriate for your individual facility.
I think that, and just want to, as we're all of you are thinking about what to do next after this, is maybe it is just to pick one little thing at your facility that you can think of that you could do better. Again, it doesn't have to be the big thing that we talked about with, changing antibiotic line, but just one thing. And so that if you're not accustomed to kind of doing these quality improvement projects, picking something small is a really good way to get things started, and just to feel what, the mechanism, the mechanics of all this. And then, but it's important to kind of think for every project you identify is that you have to have a way to measure it. And that's the important thing, because in the end, that metric is what you're going to correlate with your success, and as well as anything you do that may affect the DOT, which again, DOT is not really a great way to determine you're going to address all your other issues. So, but we're just kind of starting with that because that's the thing that everybody kind of hears about. But I think that pick a small project and then pick a metric that will help you to determine how successful your whatever intervention you choose to use, and then and go from there. And then you can start building from that point up. So whether you want to just decrease the number, I think someone mentioned about asymptomatic bacteria. That's a great example. That's a good project to start because you can correlate that easily. The antibiotic use with and depend on what you're doing. We at Billings Clinic are trying to decrease the number of urine cultures that are being performed inappropriately, because we see so many just straight up urine cultures being ordered for no reason at all. So that, so you can correlate the number of antibiotic of patients with inappropriate urine culture with the number of antibiotics that's being prescribed, and that's a great metric. So just something like that, as you're kind of identifying things around your facility, those, start small and then build from there.
Another, I think, even maybe babier step than that we found has been particularly helpful in a lot of the critical access hospitals is just asking providers simply to document antibiotics in their notes. And it's especially problematic with providers that are seeing swing patients because they're not being seen every day by the provider. So they may get a call from the nurse and say, urine smells foul, can I get an antibiotic prescription? But then retrospectively, when you're looking back at that patient, you're not entirely sure whether the patient was symptomatic. Was the urine culture even appropriate? Was it just the nurse feeling like the patient maybe had a urinary tract infection? Simply having that documentation in the note saying, patient is symptomatic, these are the symptoms they are demonstrating, and here's why I'm writing the antibiotic I am, and here's why, is really helpful when going back and looking at data.
Well, thank you, everyone. It is almost noon, but do we have any other last 10-minute questions or comments? I do want to remind everyone this is a monthly webinar series, so our next webinar will be October 6th, same time, same week, but 11 a.m. to 12 p.m. We do have some comments in the chat. So I think to Jenner, how do you get nurses and doctors to document that?
Yeah, so it is a challenge for sure. I think the best way to do that is to find one provider in your facility that's really supportive of the antimicrobial stewardship program. Hopefully that can be your stewardship lead that will then kind of nudge the other providers and say, hey, this really is important, because if you tell the providers 6 times a day, they're just going to get annoyed that you're telling them that. But sometimes having a medical director say, this really is important, here's why. The other thing you can do is, give them some data. Say, look, I had data on all of these patients that was documented that these were the symptoms. So I knew that this wasn't asymptomatic bacteriuria. So these number of patients were super easy to evaluate and say this antibiotic use was appropriate versus not. Whereas this list of patients that didn't have that documentation, we had no idea. And it took us, over the course of a day, trying to figure out why this antibiotic was prescribed and if it was appropriate. So there's definitely not an easy answer to that. I think it has a lot to do with the personalities within your institution. Some places have a medical director that will say, look, it's not an option, you have to document. There you go. Some facilities have actually put it into the template for their progress note, so that when they do like a dot phrase and it just pops up a template that they fill in, it's actually a separate area that populates. So it's an antibiotic note if there's an antibiotic prescribed, and then the provider doesn't have to think about doing it. They just have to fill in the required documentation.
Jenner, could facilities put this into like their AMS policy, stating that providers, when treating these types of infections, would document this as part of their policy?
Yeah, they absolutely could.
Or yeah,
Again, something that's going to have to be agreed upon by medical staff, because it's hard, because you don't want to put off the providers by saying, I need you to do this, and then they don't want to cooperate with you at all. So it's kind of a, pick and choose. It can be really helpful if we can get this done. This is a really good step, and it's helpful for everybody involved. It's also really helpful for providers that come in following that provider. If they're not the only provider in that facility, then they have a much better idea of what the thought process was when they take over that patient. Dr. Koo, do you have any other input on that?
No, I think you touched them all, and it's really a question of trying to reason with them to, it's on a spectrum of trying to reason with them to penalize them, then don't do it. But I think that, certainly, I think that it may probably going to have to fall somewhere in between, and you have to tailor it to your facility. And but this is where having really good, getting good support, backing up from your C-suite and your medical staff a committee to do this, because this is you really have to kind of treat this as ingrained as what they do. And this is not just for antibiotics, but anything else, like putting a catheter in. Make sure that you document that this patient has a central line, because I sit in a lot of that addressing CLABSIs and CAUTIs because of and there've been a lot of issues that we have experienced because of poor documentation. So and sometimes you just going to have to say, you just have to ask the leadership to endorse that, and so that they will kind of will be put in a position where they'll have to enforce it. So but anyway, again, whatever works for your facility, go with it. There's no one way to do this.
any final questions or comments? Anything from you, Vince, or Dr. Koo or Jenna, that you guys wanted to say before we end today? Well, as always, thank you for joining us. Next